Hello and welcome to the lecture on humidity. So we'll be covering the chapter 7 material. The big thing here is going to be when do we use humidity, why do we use humidity, what kinds of humidity are there, and then basic ways of understanding when we would switch over from one kind of humidity to another, right? Active versus passive humidity, and we'll get into even non-invasive versus invasive humidity as we go along here. So let's dig in. So just some basics on humidity. The nose and the upper airway have the purpose of conditioning the inspired gas. Well, what do I mean by conditioning the inspired gas? Well, anytime that you take a deep breath in through your nose, it's got to go through the vibrissae, the little nose hairs at the front of the nose, through the nasal pharynx, through the concha, and all those things that have a high amount of mucus in there. I have a high amount of pseudostratified ciliated columnar epithelium cells in the posterior 2/3 of the nasal pharynx there. So those things will help to humidify, right? So I have lots of surface area. Those concha, the turbinates, they slow down the gas because they make it turbulent, right? So the turbinates will slow down the gas and allow for dwelling time of that gas to pick up humidity or water content from the nasal mucosa, as well as heat from all the surface area that's in there. And the heat would be all that vascularity that's in there. Have you ever had a really, really bad nosebleed or seen one? Right? So there's a lot of vascularity that's in the nasal pharynx. So when we're looking at this, when we're breathing in slowly through our nose, we're having dwelling time that will allow for us to pick up heat and humidity with the gas that we're breathing in. Not only that, but the cilia, right, the mucus and cilia and the vibrissae, they help filter and trap pathogens. So they help protect. So when we look at our nose, it filters, protects, is one of the major functions that it does, besides heating and humidifying the gas. So when we talk about conditioning the inspired gas, it's a very important thing. And that's something your nose naturally does. And so when you have this increased surface area, when you have that nasal mucosa, right, that really helps humidify gas, that's going to help make sure that that gas is ready to go and purified as much as it can be before it reaches the lungs. So the vibrissae and the pseudostratified ciliated columnar epithelium cells, PSCC there, they really do help filter that inspired gas, and they really help us show a value in what we're doing with spontaneous breathing. So you're like, why do I need to know this? Well, one of the big things is when we bypass the upper airway, that's going to be one of our primary concerns, because do we have that gas conditioned appropriately that's safe for that patient? Well, no, we don't. And so that's why we need to make sure it's filtered, it's heated, humidified, it's good conditioned gas when we bypass someone through a tracheostomy tube or through an endotracheal tube. So we need to make sure that that's good as well. What about people that we give non-invasive support to? What about people that wear their CPAPs at night? What about people that are on non-invasive ventilation in different settings? Well, we're giving a high flow rate. Even if we're doing high flow rate with oxygen therapy, we need to make sure it's heated, humidified, because we're going to dry out that mucosa. We're going to cause a lot of flow against that cilia. So our ability to humidify and protect are diminished. And so we need to make sure whenever not only we bypass the upper airway, but if we're using high flow with the upper airway beyond what the patient can do, then we need to make sure that that gas is conditioned appropriately. There's something called the isothermic saturation boundary, or the ISB. You'll see it right there. The ISB is usually around the 5th rib, 1 centimeter below the carina, according to one resource. According to another resource, I believe it's Egan's, 5 centimeters below the carina. It's not a point you can actually see anatomically. It is a theoretical point where all the gas is conditioned into your lungs at body temperature, pressure, saturated. And so when that gas is conditioned, hopefully it reads 100% humidity and body temperature, pressure, saturated, at the isothermic saturation boundary, whether it's 1 centimeter below the carina, 5 centimeters below the carina, right? It's all depending on which resource you're going by here. But when we're looking at this, by the time it reaches a certain point in our lungs, that's the ISB, that gas should be conditioned for your lungs. Well, why do you need to know about this theoretical point? Well, one of the big things with that is understanding that if I breathe in a bunch of cold gas, really high flow oxygen, that's cold gas, right? I'm just breathing in high flow, right, with just cold air, right? One of the things that could easily happen is I could have the inability to condition that gas, and cold air will reach deeper in my lungs. Well, if that lung tissue that's used to having nice warm gas now is getting cold gas, that's very dangerous, because when we get that cold gas, it can cause mast cell destabilization, which will then lead to your anaphylactic stuff. It'll lead to your bronchospasm. It'll lead to all that destabilization, that mast cell destabilization can really lead to that cascade that leads to bronchospasm, inflammation. That's why some people that that participate in athletics have what's called exercise-induced bronchospasm. Well, it's because they're breathing in really heavy and deep through their oropharynx. They're not conditioning that gas to good heat and humidity. And by the time it reaches their lungs, that lung tissue is getting cold gas that it wasn't getting before, and then they develop a bronchospasm. So we need to make sure that that gas is properly conditioned, whether we're using non-invasive high-flow oxygen therapy or invasive therapy. We need to make sure we're conditioning that gas. Physiologically, it's appropriate for what our lungs are used to. Right? And so here's a picture. I love putting in these pictures here, but here you see that picture, roughly the ISB, right? And they say it's around this area, right? It's during normal nose breathing, but during dry gas breathing, what happens to the isothermic saturation boundary, right? You see it moving down here, right? It's moving down if we do things like dry gas administration, or we bypass the nose, or we bypass the upper airway. Those things will happen, and that can cause a massive shift in their ability to get gas flowing smoothly down their lungs, because with bronchospasm, their airway resistance increases, and it makes it harder for them to get gas down into their lungs. Well, first, do no harm. We don't want to be the cause of this. We want to actually help their lungs function the most it can. And one of the things we can do is to make sure we're properly conditioning that gas to help avoid any potential complications. All right, what are our artificial responsibilities? So the upper airway, whenever we bypass it with an endotracheal tube, a tracheostomy tube, even patients with permanent stomas, that puts the patient at a lot of risk. What will warm the inspired gas if they're breathing through an open stoma, right? Hopefully they're breathing in some through their nose, but odds are most of that gas is going through that stoma. So what will warm the inspired gas? What filters that inspired gas? What happens when this gas reaches the isothermic saturation boundary and it's not conditioned to body temperature, pressure saturated? What does pseudostratified ciliated columnar and mast cells have to do with any of this? And then do we really need to heat, filter, and humidify non-invasive in the upper airway, or even if it's not bypassed? Absolutely. So what warms the inspired gas when they have a stoma, right? When they have a tracheostomy tube, when they have an ET tube? Hopefully that's us, right? That's you. That's you listening to this. You're learning that, hey, whenever the upper airway is bypassed, we need to humidify that. So if we don't, we could cause a lot of issues, especially when we're talking about things like patients with thick secretions, could cause a lot of mucus plugging issues. What neonate, pediatric, adult, right? You name your patient population, it can cause a lot of issues. What filters that inspired gas? Hopefully that's you as well, right? That's making sure we have the appropriate filters. We're using medical grade gas as well that's filtered and purified. Although a lot of ventilators, on not only where the gas comes back into the ventilator, but where the gas comes out of the ventilator, we're going to have a filter there too, just to help make sure if there is any impurities in there, that we'll be able to filter those out before they go to a patient. These patients with open stomas, these patients with open trachs, they're more prone to infection because what's their ability to filter that, right? They're bypassing their natural filter of their upper airway. So that's going to be a lot harder. They're going to be more prone to infection. That's why breaking a ventilator circuit can lead to a ventilator-acquired condition or ventilator-associated pneumonia, because we're bypassing that and we could potentially insert a pathogen that could easily lead to an infection because they don't have that ability to trap it and get rid of it before it reaches into their lungs. What humidifies the inspired gas? Hopefully that's you as well, right? When we're bypassing an airway or when we're using high flow oxygen therapy of any kind, we need to make sure that that's humidified, because if it's not, like I said, it can make for a lot of issues, including mucus plugging, bronchospasm. Those are pretty significant issues. Both of those will increase air resistance, make work of breathing harder. That can cause harm, that can cause trauma to that patient down the road. So we need to make sure that we're not adding to the severity of the scenario and give them humidity that they need. So what humidifies the inspired gas? Hopefully it's the upper airway, but if they're bypassed, we need to be humidifying that gas. What happens to this gas if it's not conditioned to body temperature, pressure, saturated? Well, when this gas reaches the ISB and it's not a BTPS, it will cause a destabilization, can cause a bronchospasm and inflammation response. As a response to bronchospasm and inflammation, you create mucus. So you're literally creating a trifecta. You're creating inflammation that leads to bronchospasm, that leads to mucus accumulation, right? So all three of those, is that going to make your patient better or worse? Odds are that's not helping anything. That could make them worse. So make sure that you do what you can to condition that gas appropriately. What does pseudostratified ciliated columnar mass and mast cells have to do with any of this? They're what your body naturally has to filter and humidify, right? And so that's something you have in your posterior of your nasal pharynx. The posterior 2/3 of your nasal pharynx are aligned with PSCC. Your airway, once you get below the vocal cords, are aligned with PSCC until you get to simple cuboidal in the transition zone and simple squamous in the respiratory zone, right? Some of that should be memory back when you were in pulmonary A&P, but when we're looking at that, that's the big thing that we would see if we have dehumidified, deconditioned gas reach that area of the lung where it's supposed to be conditioned. And that's what's going to lead to that bronchospasm, inflammation, and mucus accumulation. So do we really need to heat, filter, and humidify non-invasive? Like non-invasive, whether it's CPAP, BiPAP, any type of non-invasive high-flow therapy? Do we really need to do that if their upper airway is not bypassed? Hey, Derek, we're going through their nose, right? They're breathing through this oxygen mask, right? Well, here's the thing. They're breathing such high flow rates. There's so much gas flowing at such high velocities and flow rates through their airways that it's not enough dwelling time to filter, heat, humidify, right? So we do need to give them some sort of humidity. Can they dry out? Can it be very uncomfortable giving them high flow rates without any humidity? Absolutely, right? So even when we are not bypassing the upper airway, we need to go ahead and provide some active humidity when we're doing things like high flow therapy. All right, the big picture, right? You're going to see some fun pictures here. Every time the upper airway is bypassed, or if there's an increase in dry gas delivery to the patient, humidification is a key component to avoid complications. You want to have an easier time. Yes, humidifier alarms go off all the time, but would you rather deal with a humidifier alarm or a patient that plugged off their endotracheal tube like you see in that picture, or plug off their tracheostomy tube like you see in that picture? I would much rather deal with the heater alarm and deal with all that business than having to deal with a plugged off artificial airway, right? So there are a lot of complications, a lot more serious complications when we don't provide humidity in areas that we need it. So potential complications, you may ask, right? Bronchospasm, we've already talked about. Mucus plugging, that's a big one that could lead to hypoxemia, that could lead to a code, especially with pediatric patients where the pores of Kahn, the canals of Lambert really aren't functional yet in your smaller pediatric patients. That can be a very significant thing. Air trapping, of course, if mucus can't get around that plug and it's stuck in the respiratory zone and can't really get out, like I said with the collateral ventilation, the pores, the Kahn, the canals of Lambert, it's not going to allow that mucus to work its way up and out. So that could lead to air trapping where when you breathe in, your airways expand. When you breathe out, what happens to your airways? They collapse and then gas is trapped because of all this mucus plugging. So that could increase your air trapping and could cause a lot of compliance issues on top of airway resistance issues. Well, now we're really getting somewhere here. That can be very bad. That can lead to a pneumothorax. That could lead to cardiovascular instability because we're building up pressure on the vena cava and squishing it, right? So that's a very poor thing. Increased airway pressures if they're on volume ventilation, right? That's why, remember, the two types of ventilation. We can use pressure to deliver a breath, or we can use volume to deliver a breath. If we're using volume to deliver a breath, which most pediatric through adults we are, we're going to see much higher pressures used to deliver that gas because it's got to make its way past those obstructions in the airway. So their peak pressures could be very, very high. It can be very hard to get gas to the respiratory zone. Well, what happens if we don't get enough gas to the respiratory zone? They start to hypoventilate, right? They start to build up CO2. They don't get appropriate gas exchange, and they can have air trapping too with this. So now we're asking for hypercarbia and poor compliance issues, right? We could see things go very south very quickly here. Occlusion of the airway, and that's these pictures that I put in here, right? So hopefully you enjoy these pictures. Occlusion of the airway is a very serious thing. One of the best things about a tracheostomy tube is most of them will have an inner cannula that you can go ahead and remove if you need to, if there's a mucus plug in there, and then just replace it with a brand new one. And if there's a mucus plug in there, we don't have to worry about taking the whole artificial airway out. We just take the lining of the one that's currently in there, which would be the inner cannula, and then we replace it with a new one, and then we connect you back onto the ventilator. Ideally, we shouldn't get to that point. We should have seen the signs before that they were having lots of thick mucus and issues there, but if we do, that's one advantage there. With an endotracheal tube, there are devices out there that you can stick down the endotracheal tube to help clean out the ET tube, but if it plugs off altogether and it's an airway obstruction, that might be a case where you have to extubate, or in a tracheostomy tube, if it doesn't have inner cannula, you might have to decannulate to help save that patient. So hopefully you take care of this well before then. You have good systemic hydration, you have mucolytics on board, right? You have other things going on before you get to this point, but if you do get to this point, it can be very, very serious. The other thing, besides those occlusions and potentially having a code on your hand, would be discomfort with the device, discomfort with non-invasive or CPAP. That discomfort is going to be a pretty significant thing because a lot of people be like, well, lots of flow going through there. It's cold. It feels very hard. Some people get headaches. One thing on the neonate population, I was reading this in the Egan's book the other day, was that if you do high flow with a neonate and it's not warmed, it could actually cause cooling of the brain because it's such high flow. So we need to make sure that we're having not only the comfort part of it, but we're not avoiding any other serious issues like what I just said there. So discomfort is going to be a big thing. It's going to be a lot more comfortable if we have good, adequate humidity and heat to it. So these are potentially serious things to think about. The big thing is making sure we do use humidity. I know it's a lot less issues for us when we don't use humidity. Hey, we don't have to worry about a heater alarm. We don't have to worry about replacing water. Yes, those things go away when we're not using humidity, but what's your exchange? What's your return of investment for that? A lot of potential harm and damage to that patient. So if it was you or a loved one, you'd want them using humidity, right? If it was you on that other side, right? So that's one thing you have to worry about. If you don't use humidity, a lot of bad things can happen. All right, the system. So these are just different ways of providing it. Mechanical ventilation should, hey, look, there's a number here that looks pretty important to know. Mechanical ventilation should provide at least 30 milligrams per centimeter water per liter, right? 30 milligrams of water per liter of absolute humidity at a temperature range between 33 and 37 to an inspiratory flow of 20 to 30 liters per minute. That's a lot. All right, did you hear me say that? I'll repeat it again. Mechanical ventilation should provide at minimum 30 milligrams of water per liter of absolute humidity at a range between 33 and 37 degrees centigrade for inspiratory flow rates of at least 20 to 30 liters per minute. So we need to make sure that we have at least that. Those are the minimum requirements for mechanical ventilation. So those sound pretty important, right? And these are directly from your reading material. So yes, I will expect you to recall that information as well. So that's something to look at. But does non-invasive and high flow, high velocity therapy fall into this rule? Absolutely it does, right? And that's where I have the picture here. This is more of that non-invasive that we're talking about here, but yeah, they absolutely fall into that rule. Some hospitals will prefer a delivered temperature between 33 and 37, so follow the hospital's policy and procedure when it comes to humidification. Of course, they have those for a reason, and it's always good to know their reasoning, but these are all directly from your book, so we'll go with these for now. There are a lot of different ways to humidify gas. They include passover humidification, vapor phase, heated wick, which is this one that you see down here, this yellow one. There's a more modern version of this out there. That's just what I have there. And then heat moisture exchangers, which I have some pictures of those later on, and we'll talk about those. So the big thing is to know the system that your hospital or your facility utilizes, and then how to optimize it for your patients. Some of these you can adjust the humidity content within the heater. Some of them you can adjust the heater temperature. Sometimes you can pause these for things like nebulization, right? So those are all things that you can do that can really help out. What about water? Well, when we're doing this, refilling is best accomplished by using a closed feed system. How do we make sure that we're just having adequate water levels at all time? We can hook them up to either what looks like an IV bag that automatically fills it, or we have a spike into the heated wick ones where we have the water that will continually be pulled through there to pick up humidity. So we have that reservoir of water that will just continually refill it, right? So that's a closed feed system. You'll see this very commonly with mechanical ventilation and most non-invasive ventilators. Now, home CPAP units, those things, they may have to fill manually with sterile water, but traditionally in the acute care setting, you're going to have an auto feedback system. So make sure you got plenty of water to replace those if they start looking low. Make sure you bring one. Be kind to the therapist behind you, right? You don't want that running dry and then having issues. So water level is maintained in an auto feedback system from a bag or a float feed system, right, that we talked about already. And here you can see the float in the picture, right there. Right, there's that little float in there. And then this whole circuit up here, that is what will spike into a bag. So this is just using the Fisher-Paykel system. It spikes into a bag, and then the bag will automatically empty when that float moves. It'll allow for more water to go into that chamber. So the big thing here is it can better regulate, the water temperature can be better regulated in this system because it has a continual level. It's not changing water levels all the time, right? Is it easier to heat up something that has a lot of liquids in it, or is it harder to change that, right? So that's one of the things that we have to worry about here is our water content. If it changes, the level of water changes, then it can change temperatures. Well, here you're going to have a pretty steady water level, so it makes it a lot easier for the heater to maintain that constant heat compared to just pouring a ton of water in there and then it's really cold and it doesn't have enough time to warm up that water to pick up the heat, right? So that's a good advantage of an auto feedback system, right? So there is a risk of potential contamination when the circuit is opened. If you have to re-pour and pour and pour, right? Open up the circuit, pour new water in, close the circuit again, compared to using an auto feedback system. So anytime you break that circuit, it puts that patient at high risk for a pathogen. It puts them at risk for anything like that. So we have to be very careful. The heater, traditionally, most of them are servo controlled. Usually there's a temp probe in the circuit, one that's proximal to the patient, one that's proximal to the heater, right? So we have one where the circuit will read, hey, okay, this is the heat that I'm putting out directly at the heater, and then this is the heat that's actually making it to the patient once it's gone through the circuit. And so it's going to read back what the one closest to the patient is to the heater and tell, okay, I need to increase my regular temperature to make sure that by the time it reaches the patient, it gets to that optimal temperature I'm programmed for. So it'll automatically do that on most of your modern heaters. So the heater, that's that servo control, so it's going to adjust it throughout that circuit. High temperature alarm is usually set around 37, 38 degrees centigrade. We try not to go above that. And then low temperature is usually at 30 centigrade is appropriate, but it just depends on what our goals are for the patient. Are we doing permissive hypothermia therapy, right? Are other factors in play, right? Those things may come in to factor when we're looking at what temperatures to use for our patients. All right, if the temperature in the circuit is less than the temperature of the gas leaving the humidifier, there's condensate that forms, right? Condensate that forms, that's water just jiggling around in that circuit. And that could cause a lot of issues with not only the gas flowing to the patient could be more turbulent, we could also have obstruction of gas flow, we could also see higher pressures, we could also see auto cycling where the ventilator decides to give more breaths than it should, right? And we can see that neonate through adults on the ventilator circuit. So that's something we got to be careful, is that condensate that forms. So that's why I put do the dance in there. If you see the circuit dancing, right? If you see the circuit wiggling around, shaking around like that, that's a sign you might have condensate that forms. And that might be a sign you have to drain the circuit or do other things to help avoid that. Like take the fan from blowing on the circuit or hide the circuit away from the fan, things like that, right? We need to look at what's causing that condensate to form. So some people will call this a condensate rainout. So if you see the term rainout, oh, there's a lot of rainout in their circuit, that's a very common term that you could hear out there. And that means the room temperature is cooler than what the heater is. And so that means water will condensate and pull out and collect in that circuit. So fans blowing in the room can cause a lot of extra work for us. There's a reason for those. So, and sometimes you can't control that. That's beyond our control. What can you control? Well, you can move the circuit around, you can hide the circuit under some blankets if that's appropriate, right? Follow hospital's policy and procedure. There's different things you can do. Even with non-invasive circuits at home, people will cut the toes off of really thick socks for CPAP circuits, right? And then they'll line the circuit with the socks, right? Like almost like a big sock. To help avoid that condensate, so that way they can have their heater on at night with their CPAP or nocturnal BiPAP, and that way not have a bunch of water that forms and just gushes and gives them a little bolus of fluid every couple of hours. So we need to be creative in making sure that's appropriate. The other thing too is there are circuits that have water traps in them, and that might be appropriate if we have this issue, especially if it's a room that's really drafty or a patient that we're having to blow fans on, right? We need to look at what we're having to do to help this overall situation. Heated wire circuits, more expensive than non-heated wire circuits. They help reduce rainout. They won't cure it traditionally, but they do help reduce the amount of rainout. So that is something too, if a patient has a lot of rainout and you have the option to switch to a heated wire circuit, that is an option that could be beneficial in that scenario. But be sure to look at for rainout or dancing when you evaluate the patient. Each time you go into the room to look at that patient, is their circuit appropriate, right? Check their circuit out. You're not only evaluating the patient, but also the machine, the interaction with the machine, right? Are they comfortable with the ventilator interaction? Is there other things going on that I should be looking at? That's one of those things, right? Look at the circuit. Is there anything built up in there? Is there any bad things in there that we should take care of, right? That's a part of your assessment when you go in to see these patients. It's not only the patient, but also their interaction in the circuit and everything that leads up to them. Because that could be a safety issue, like I said. Auto cycling, building up a bunch of things can cause a lot of abnormal side effects and cause pressure issues, flow issues. So check the circuit out each time you go in there. So if a deficit exists between humidity provided and the amount needed by the patient, you can get secretions that dry out. This is pretty significant. So drying out of secretions can cause them to get bigger and cause mucus plugging, right? That's going to be a significant issue. The secretions will get thick, sticky, hard to move out, and you're going to have things with mucus plugging, which could cause air trapping and autopeep and cardiovascular issues, right? We're going down this whole train again. So potential hazards of these again, I just listed a bunch of them, right? Air trapping, mucus plugging, bronchospasm, creation of more secretions, right? Discomfort, right? You name it, right? There's a whole list that we went over earlier, and I just put 3 bullet points in there, but there's way more than that when we looked at that list. So understand there's a lot of hazards when we have a humidity deficit. So make sure you're using appropriate humidity, right? You can also tell by looking at the patient's secretions as well, the pulmonary secretions. I feel like I shouldn't have declared that one, but here we are. So when you're looking at their pulmonary secretions, are they thick and sticky? If they are, that could be a sign that there is a humidity deficit, that we could help with that. And that could be increasing the heater temperature, that could be changing the humidity level if we have a certain type of heater for that. So that's going to be knowing your device. Or if they're on a heat moisture exchanger, then switching them to a humidified circuit. Right? So those are all things that we can think about to help by just looking at the secretions. That could be also a helpful point to be like, are they dehydrated as well? Look in their eyes and nose, things like that too. But overall, what can we do to help with their humidity? That's what you have to assess at the bedside. If they're thick and difficult to suction, right, the secretions are thick and difficult to suction, or they're bronchial casts or plugs, you might have a humidity deficit, right? That's a very bad sign. So that could be a potential another indicator, right? Thick or difficult secretions, to go ahead and do your methods to help improve the airway clearance therapy, which would include better humidity. And you can always add airway clearance therapy as long as it's appropriate to do so, or even things if it's serious enough like a therapeutic bronchoscopy and possibly diagnostic bronchoscopy if these secretions are new, right, or changing color from what they've had before. So we'll have to take those into account as well. All right, traps. I bring these up. It depends if your facility carries these or not. Some places do, some places may not. So a lot of condensate forms in the circuit. Water traps might be placed in gravity-dependent parts of the circuit to catch that rainout. So that's, like I said there, that's if your hospital carries them. And here are some pictures, right? You'll see some pictures where the circuit here has a little area and it's spring-loaded, so you could empty it or suction it out without sucking gas away from the delivery of gas to the patient or anything like that. So that's something that you could consider if your hospital carries such a thing. Water traps should be emptied regularly in a way that protects them from aerosolized spray. In other words, it protects you from that spray. If the patient has some sort of infection issue, we need to make sure that that's taken care of. Most traps will have a spring on them, like I said, that seal it when you unscrew it, so you can empty ports to drain the water or anything like that. So usually these ones will maintain a seal that won't take any gas away from the patient. It won't cause a leak in the circuit, if you will, when you have to drain these. So something to think about if your hospital has them. You got a patient that has lots of fans or in a room where there's a lot of condensate, that might not be a bad idea to avoid breaking the circuit multiple times. Is break it once, change the circuit, and then go on from there where we don't have to break it near as much from then on. All right, heat moisture exchangers. Most of this lecture is actually about HMEs. HMEs, they're great for short-term ventilation, especially if we're transporting a patient from the ICU to CAT scan and back to ICU again, or we're transporting them to radiology, or we're transporting them to MRI, right, for an MRI procedure, then coming back to the ICU. So they're great for that short term, especially for intra-hospital transports. They're great. Some people will use these in emergency rooms as well. When these patients first come in, right, a good way to make sure they get adequate humidity starting right away. They don't have to wait for a heater to warm up or anything like that. So they're great for short-term ventilation. Some places use them longer than short-term, and we'll talk about that in a second here. There is some issues here. The large dead space in spinal cord injury circuits where they'll have a Y of the circuit and then they'll have something like 54 inches of dead space. That's right, I said 54 inches of dead space. They'll have a lot of dead space because they'll be on very large tidal volumes. To avoid hyperventilation, they'll give them a lot of dead space. Well, how do you make sure there's adequate humidity through such a long circuit? Well, they might still use an HME proximal to the circuit where it goes into their tracheostomy tube. So that might be helpful there. So long-term spinal cord injury patients, those type of patients, you'll probably see heat moisture exchangers in. Because are you going to be cruising around in your wheelchair with an active humidifier? Not traditionally, right, with that water sloshing around and stuff, and refilling it and having a bag. The HME is going to be more practical for a lot of those cases. So home vented patients, transports, you're going to see them a lot in those scenarios. HMEs are contraindicated with thick, copious, or bloody secretions. Once again, we're talking about contraindications and a type of humidity, so it sounds like this could be an important point to remember. Yes, it is. It is. So thick, copious, bloody secretions, they might increase airway resistance, cause a lot of issues with ventilation, having adequate gas exchange, and work of breathing. That patient could be working really hard, especially if the HME has secretions in it or it gets too much water in it for some reason or another. It can make it hard to breathe. You're breathing through a wet cloth type thing, right? So it's going to be hard for those patients to breathe. So we got to watch out for that. If the patient has a large bronchial pleural fistula or cuffless ET tubes, like what you see with the little babies, the neonates, the HMEs aren't going to have the appropriate humidity for that scenario. If they're hypothermic, if they're below 32 centigrade, they don't have enough body temperature to heat up those, because the whole point of these is as gas flows through the HME, when you exhale, that gas is going to be passing through here and it's going to warm up that material, and then with the next breath in as it's being delivered gets conditioned by that heat and moisture that you just exhaled. So you're using your own heat and moisture, you're trapping some of that heat and moisture to condition that next breath in. So that's how they work. So if the patient's cold to begin with or hypothermic to begin with, then obviously that's not going to be very effective there. If their minute ventilation is over 10 liters per minute, we need to watch out for that, because if they're breathing very fast, very deep breathing, it's not going to be enough to catch up with them. So that could be very dangerous, very potentially hazardous, so they can dry out very easily. So very high minute ventilations. Different manufacturers will have different minute ventilation ranges on their HMEs and different sizes. Some of them have larger dead spaces than others. So you need to know your equipment too, but usually over 10 liters a minute, not a good idea, because they have such a high minute ventilation that could really not be adequate humidity for them, because they don't have enough adequate space for that. Nebulized medications, because if you're nebulizing a medication to a person, what's going to happen with the medication? Most of it's going to be stuck in the HME. Hardly any of it's going to make it through, if any. And so if we're nebulizing trying to go through an HME, the patient's probably not going to get anything effective with that dose. So if we're nebulizing, that's where we might have to switch to an MDI. Or something other than that. Small tidal volume patients is that last bullet point there. The small tidal volumes, it may increase dead space and compromise CO2 clearance. When we have patients that are undergoing permissive hypercarbia and we're decreasing their tidal volumes, let's say we get them down to a tidal volume of 4 mLs per kilo for their ideal body weight, that's a very small tidal volume, and then now you have something that can trap up to 150 mLs of CO2 into it, then their CO2s can go up significantly. So if we have someone on smaller tidal volumes, that may be one of those contraindications where we might have to go ahead and switch them over to an active humidity circuit. They can be very helpful in the right patient, in the right patient population. If you're doing short-term mechanical ventilation, it can be very beneficial for those patients. However, there are some considerations and contraindications you do need to be aware of in your practice. Also, they're known as artificial noses, right? Because what do? They trap heat, humidify, right? And here you see one that's connected to a trach tube, so the trach would go over here where I'm drawing the circle. So that would be connected there. So if someone just has an open trach, they can stick it on there, and then it's just going to humidify any gas that's going through their tracheostomy tube. So you might hear people call them artificial noses. They usually provide about 10 to 14 milligrams per liter of water. And that's at 500 to a liter tidal volumes. 500 mLs to a liter, so a half liter to a liter tidal volumes. So is it giving as much humidity as the patient needs? Maybe not so for most patients. They are hygroscopic ones that you can give 22 to 34, so much better, right, at similar tidal volumes, much better humidity than that 10 to 14. So you will have a net heat and water loss with an HME, but that's if you use it for extended periods. If I'm taking a patient to CT scan and back and we're gone no longer than 20 minutes, then I'm not looking at a net water or heat loss that we're really having there. That's a short period. So be sure to evaluate for drying of secretions if you do use this for long periods of time. And even those short trips that can dry patients out if we have a really high minute ventilation on them. So just be careful of that. You can accumulate moisture and secretions and increase airway resistance. Like I said before, a patient can cough up some mucus into these HMEs or into their circuit and block these HMEs. Or if we're trying to nebulize through an HME, which you're not supposed to, that can easily trap all that stuff and block it and make it hard for that patient to breathe. So they're working really hard. They have an increased air resistance and they can air trap, and then they're working really hard. Are we helping this patient or are we causing harm? At that point, we're causing harm to that patient. If we are using more than 4 in a 24-hour period because there's secretions, then we should probably change that patient to heated humidification. Seems like I'm going to stress that last point there. Yeah, if you're using a lot of HMEs, you're breaking the circuit multiple times. Each time you break the circuit, potential for infection, right? So the more than 4 in a 24-hour period, because of secretions, right, they're thick and sticky, they're plugging off, right, things like that, we need to change them out to a heated humidification, right? That's an active humidification indication. So you're like, Derek, when do we need to switch someone over? If you're changing out more than 4, if they have thick, tenacious secretions, right? Those are all signs we probably should switch a patient over to active humidity, to heated humidity. So don't forget, HMEs, heat moisture exchangers, can add dead space to the circuit. Some of the smaller ones only add about 50 mLs of dead space to the circuit. Some other ones can do 100 mLs, right? It depends on the manufacturer and how big that HME is, but that can be very significant. Therefore, there could lead to higher CO2 levels and make it harder for that patient to breathe and get rid of their CO2 because now they have to breathe that extra. They're not getting as much tidal volume eliminated when they were previously perfectly fine. So the other thing is the airway resistance, which is the second bullet point here. Airway resistance added 2.5 to 3.5 centimeters of water per liter per second. That can be pretty significant, especially if your patient already has an obstructive disease issue like COPD, emphysema, asthma, right? Chronic bronchitis, bronchitis, cystic fibrosis, right? Anything that's obstructive, lots of thick secretions. Anything that's obstructive, and you're adding airway resistance to that process, to that disease process, can be very significant and can be potentially harmful to that patient. So that's something else you got to consider. Do I want to add more airway resistance, or could this add more air resistance? Absolutely. So is this something you'd want to use in that scenario? Probably not, but I can't be your practitioner, right? Low tidal volume patients is that next bullet point here. Low tidal volume patients may have more impact of this airway resistance and dead space situation. So as we start to turn down, and let's say we're going to permissive hypercarbia, where we're allowing their CO2s to go up and their pHs to go down a little bit, still within survivable range, not perfect range, but survivable range. The whole reason for that is to protect lung tissue from damage. So when we're doing this, we need to make sure that are we causing harm by leaving something like an HME in place where they're not having as good of a ventilation. We should look at that. Infants, children, adults with tidal volumes less than 400 mLs are impacted the most. So once we get to these very small tidal volumes, that's where HMEs can be causing some issues, and we should look at changing that out to heated humidity in those cases. You do not, listen to me for a third time, you do not use them simultaneously with the heated humidification. It will cause an occlusion. I shouldn't have to clarify that one, but I've seen it in my practice before. So the big thing there is just if you're using an HME, great. But if you start a heater on a patient, make sure you take the HME out of line, because that HME will get saturated with all that water and get saturated with everything, and it's going to cause an occlusion and could cause a potential very, very serious situation. All right. Big things. I know I'm speaking a lot about HMEs, but take them out of line during nebulization. If we're doing nebulizers, which means you'll have to take them out of line, make sure they're clean, put a new one or put the clean one back in. Afterwards, you're breaking the circuit twice to nebulize to this patient, so that's a lot of breaking the circuit every time. Let's say you're doing a nebulizer every 4 hours. That's breaking the circuit every 4 hours for 24 hours. That's a lot of circuit breaks. It's a lot of potential for harm to that patient. But you do, if you are nebulizing and you're an HME facility or patient has an HME, you need to take them out of line because they will trap most of that nebulization. Consider an MDI is the other thought here, over nebulization, so that way you don't have to break the circuit. Here is a picture of an MDI setup in line where the patient's still on an HME, but they can do an MDI and they can time it with breath delivery. So as the breath is being delivered on the ventilator, they can do the puffs, right? Do remember with pharmacology, mechanical ventilation, if you're doing an MDI, you usually have to double your dose because timing is the most important key to this. It's a whole separate lecture when we start talking about that. But big thing here is the MDI adapter needs to be placed between the HME and the airway, and that's what you see in this picture here. This is the MDI adapter that I'm circling here, and then the HME would be back here, right? So it's placed before, so that way none of the medication that's being given to the patient on inspiration should be getting into there. On expiration, could some of the medication be breathed out and get into the HME? Absolutely. But primarily, most of that medication should be delivered, and you're not going to be causing any occlusion or any issues of getting that medication to that patient. So, follow policy on changing. Most manufacturers of HMEs will have you change them every 24 hours, but there are some hospitals where they'll let you go 2 to 3 days with the same HME. So look at your hospital's policy and procedure. Understand what the manufacturer says, what the hospital policy says, especially with breaking the circuit. They may have that more longer time period approach there as well. More than 5 days of mechanical ventilation, if this person's going to be on for a prolonged period of time, usually better to go ahead and get the heated humidifier system to help avoid the secretion retention or avoid issues there. So short-term ventilation, long-term, especially with mechanical ventilation on your critical care patients, not your long-term home care patients, but those guys you need to be very careful of. So when we're looking at long-term use, anything that's longer than 7 days usually will increase the rate for endotracheal tube occlusion. It's because the secretions can get dry and sticky and thick, and when they come up into the airway, it's going to be a high issue with the potential for airway obstruction. So that's why we try to use it for just short-term situations in the critical care context. Long-term home vent patients can use for long periods if the secretions are not a problem. Most of the time, they're not dealing with significant illness or sickness that causes a lot of secretions, so they may not have that same issue the acute care situation has.